Okay, so the next part of the agenda is that we're now going to go to the fellows for them. Emma, is that right? Tell me if I've got this incorrect. I believe that's where we are now.
Yeah, that's right. We're going to hear from our fellows now, and they're going to do this in two sections. So we'll go through the first set of fellows, telling you a bit about the projects that they've done and their outcomes.
Okay.
So
we're going to start with fellows who were in Ghana. And they should know what order they're in, but I will also let them know. So we're starting with Edwin. So over to you, Edwin. If you put your video on, if you can, that will be helpful. And I will, if you let me know when to click next, I will go through the slides as well.
Okay. Hello, everyone, and glad to have you all on board. Our project was looking at delayed prescribing within the hospital that was part of the LECMA. Within the hospital that was part of our project, which is LECMA Hospital. And I just want to go through with you briefly what we did and some of the outcomes. Next, please. So the hospital had an OPD department, and that's where the project was based. And the idea for this was that anyone that came in with an upper respiratory tract infection, based on the clinical judgment of the clinician, was then put into 4 different categories. The first category was not prescribing any antibiotics. So they'll be given a leaflet on how to manage it with appropriate food and drinks and minor ailments. The second group were given a post-dated prescription, which they could take to a local pharmacy after 3 days if symptoms had not improved. And then the third was a follow-up appointment in 3 days' time for reassessment. And then the fourth group were given a prescription which was left at the hospital pharmacy to collect in 3 days, once again, if their symptoms did not improve. And within, you could see on the right-hand side, the slide, the actual patient journey. Within each group, they were given an appropriate leaflet on how to manage their symptoms effectively, with or without antibiotics. Next slide, please. And the results, we did 2 forms of results, quantitative and qualitative. And the project itself ran from December 2019 to February 2020. And 142 patients were involved altogether. And of these, 87% were female, 52 male, and 3 did not specify a gender. The most common diagnoses were sore throat, common cold, and sinusitis. And regarding the various models, we found that actually none of them made a huge difference in terms of the final outcome. But with regards to the follow-up, the cohort 0, which were the ones that were not given any medication at all, had 16, and cohort 1 had 44, cohort 2 had 21, and cohort 3 had 21 as well. Only 1 patient out of the 142 ended up taking antibiotics after within the 10-day period, and successful contact were made with all 141 patients. And so far, they were none of them needed antibiotics, and they were all very much happy with the service. Either they rated it on a Likert scale as good or very good, which was quite pleasing to hear. Next slide, please. Yeah, sorry. So we then looked at the how this could be translated on a much bigger scale, if possible. And sorry, Diane, I can't see the slide properly. Could you scroll to the left for a bit? Yeah. That's it, yeah. A bit more. Yeah.
I'm not able to.
Okay, sorry. Right, let me try and see if it's my screen. No, it's not my screen. So we then looked at the learning outcomes, and through this 3-month project, we actually found that it is safe to implement delayed prescribing, because interestingly, prior to setting this up, literature review did not indicate that there was anything like this happening in low middle income settings. And from this, we also extrapolated that based on the antibiotic data that we had from LECMA, that we could, in a year, we could be saving about 6,000 antibiotic prescription in LECMA alone. So points to consider is how to engage and train all the staff involved, how to promote the service widely, and possibly look at bringing it within the bigger setting, for example, including more hospitals locally. The graph that I've shown on here was actually we looked at the antibiotic prescribing, and interestingly, what we noticed was February time, there was an increase, which discussion with the doctors indicated that they were not expecting that to happen. So we kind of a question mark possible COVID impact. Next slide, please. And the fellowship benefit for me personally, I've listed a few, but the main one for me was the alignment with my PhD, because I'll be looking at antimicrobial resistance or antimicrobial stewardship within community pharmacies, and this really aligned with that. And also for the NHS benefit was championing AMS within community pharmacies, because for me, in a low middle income country, that is where it actually sits. So I'll now hand over to my colleague, Joyce, who will share her project with us.
Hi, my name is Joyce, and I'm the lead pharmacist for HIV and infectious diseases at the North Middlesex Hospital. We had a new partnership between us and Kolebu Teaching Hospital in Ghana. Kolebu Hospital is a huge hospital. It has about 2,000 beds and is a large referral center within Ghana, but also within other countries within West Africa. Next slide, please. So our project was all about building capacity in a sustainable way. And in particular, we're focusing on pharmacists. And one of the easy ways that we thought that we could do this was by rolling out the CwPAMS app to improve access to guidelines. Ghana has national guidelines called the Standard Treatment Guidelines. They're available as a book that is published every so often. The app also had lots of other really amazing resources like the WHO Aware List and different AMS tools and resources that people could use throughout their working day. And what we planned to do was to train 12 super user pharmacists. These pharmacists were then asked to then go and train and recruit doctors in their wards and clinical areas. They were also asked to recruit other pharmacists. And when they recruited people, they collected their contact details. And at the end of a particular period of time, we would then send them a survey electronically to see what they thought about the app in terms of how we could improve it and how we could make sure that they had the information that they needed to do their jobs. Next slide, please. So in terms of the responses, we had a lot of contact details for doctors, but unfortunately, not many of them responded to the survey. So 94% of our responses were from pharmacists. And of those, 94% had heard about the app from our visit to Ghana in June 2019. Some people use the app only once a week, and this could be a reflection of the seniority of pharmacists that were involved. 4 people hadn't used the app, and that was because they had technical issues. The app would not open, or different issues to do with the app. Most people found the app easy to navigate and reported that it was easy to recommend to colleagues, and most people recommended that they would indeed recommend it to colleagues and promote it. However, when we looked at the data, most people only recommended it to 5 colleagues or less. It was a handful of people who recommended the app or promoted the app to more than 6 people. In terms of other results that we had data to show that the impact on patients' outcomes was positive, and that the app improved ability to ensure antibiotics were being prescribed effectively, and that people were confident and comfortable in using the app in lots of different settings, in MDTs, on the ward, in front of patients, with colleagues who were more senior to them or more junior to them. There was no issues in terms of looking at guidelines whilst people were at work. Next slide, please. So this is a picture of my Ghanaian colleagues during World Antibiotic Week in November 2019. They used lots of resources from CwPAMS and THET to go and promote the app throughout the hospital throughout that week. What we found was that the pharmacists found the app really useful. And we know that pharmacists are actually very powerful advocates in the fight against AMR. But what we need to do is we need to engage prescribers. It's doctors who prescribe antimicrobials in Ghana. So we need to find out what their training needs are, what information they need at the point of prescribing to make sure that they prescribe the correct antibiotic at the correct dose for the correct duration. Next slide, please. So the impact for me and the NHS, I think, was actually quite huge and quite amazing. In particular, when we came back from Ghana in June 2019, we immediately set out to change how we run our PPS within my hospital. I know that personally, I think more about how AMS impact, how my actions impact on antimicrobial resistance. But more than that, we learned about lots of resources that we've used quite frequently throughout the year, in particular the behavioral psychology sessions, as we've worked really hard to improve on our medicines management policies within our hospital. I found that the training that we had throughout those sessions has been extremely useful. And it goes without saying that the travel to Ghana was amazing, and we'd love to go back. Once the pandemic is over, we'd like to go back and finish the project. But also we hope that our project will move on from being a pilot to being a long-term sustainable project. I'll hand over to Misha now. Thank you.
Thank you, Joyce. So my name is Misha and I'm a sponsor regulatory advisor working at University College London, and I'm also a community pharmacist. So my project was based between the partnership between University College London Hospitals, University of Health and Allied Sciences, and Ho Teaching Hospital, which is based in Ho in the Volta region of Ghana. So my project team actually consisted of 3 people from the UK, myself, Dr. Yogini Jani, and Dr. Ene Kipakori. And in Ghana, we were very lucky to have a team of about 12, which was led by Dr. Kinley Stodu. Next slide, please. So our project was based on the objective to improve pharmacist knowledge, health, awareness and practice around antimicrobial stewardship. And as part of this, I was responsible for delivering the Global Point Prevalence Survey training to the healthcare providers that attended educational training sessions. And I was also responsible for co-delivering these education training sessions, which covered AMS and AMR topics, as well as conducting semi-structured interviews with these healthcare providers to gain a better insight and understanding on their AMS knowledge and what needed to be done to further improve the health system at Ho Teaching Hospital. So we actually completed the Global Point Prevalence Survey on the 18th of July in 2019. Prior to this, I delivered a half-day training on the actual purpose of the Global Point Prevalence Survey and data collection methods to healthcare providers. So we actually on the day had about 7 multidisciplinary teams which covered 2 to 3 wards each. The results, as you can see on the left-hand side by the pie chart, so out of 112 inpatients, 88 were on antibiotic treatment on the day of the survey, and the prevalence of antimicrobial use on the wards was 63.3% in adult wards compared to 75.4% in neonatal wards. We also found that the most common diagnosis, as you can see on the right, was malaria, which due to the current season and climate wasn't an unusual thing to have observed. In terms of what went well during the GPPS, we found that each team being comprised of multidisciplinary staff was really effective because each healthcare professional was able to showcase their own expertise. And we also found that prior training on the microguide was really helpful on the wards as well, because that was being able to use very efficiently. Some things that could have been improved upon would be the way in which things were recorded on medical notes. So things such as the reason in notes as to why antibiotics were being given, only 68.1% of patients had a reason in their notes, and only 59.1% of the diagnoses were guideline compliant. Next slide, please. The second deliverable that I co-led on was the education training sessions to healthcare providers in our first visit in July in 2019. In particular, I presented training on the microbiome and the wear list. Prior to these training sessions, we were asked the healthcare providers to complete a pre-training survey on their knowledge, attitudes and practice. And we found that 50% weren't actually familiar with some of the terms, such as AMS, AMR capacity building, superbug and the aware list. However, post-service results found that 90% of the respondents were then confident in understanding and they had an awareness of these terms. And then part of the second stage of the project in January 2020, myself and Dr. Jani went back to Ho and we interviewed 18 healthcare professionals, of which 5 were pharmacists. We conducted semi-structured interviews which were based on their knowledge gain from the previous training session in July. We also wanted to understand healthcare providers' personal thoughts, feelings and attitudes towards the current systems in place and what could be improved. So as you can see, some of the main themes that we picked up upon were education, in particular for patients and healthcare providers, shared learning between key workers, especially pharmacists and doctors, where there needs to be a higher level of interaction, finance and resource, and dissemination of information. This meant information going from the ground up to those higher above in hierarchy to ensure that change occurs. Next slide, please. So as you can see, this is our team out in Ghana, myself and Dr. Jani and Dr. Kipakori. All in all, this fellowship was a really, really amazing experience for me. I gained valuable insight on AMS at global level and a greater understanding of the shared vision of AMS globally. And as a community pharmacist, it made me realise there's a lot more that we can do to help educate, especially on a patient level. And I feel extremely lucky to have this experience. And I would like to thank the extra support at CPhO, especially Diane and our project lead in the UK, Dr. Jani. Thank you.
Thank you, Misha. We're just going to hand over now to Fran.
Thanks very much, Diane. I was part of the Health Improvement Scotland project working in Ghana Police Hospital and Keta Municipal Hospital. And this morning I'm wearing the scarf that was gifted to me by the team in Keta, who are actually behind me, giving me some support. So this morning I just wanted to take the opportunity to talk to you about the quality improvement project that we did in Keta Municipal Hospital, which started in October 2019 as part of my Global Health Fellowship. So Keta Municipal Hospital is a 110-bed hospital in Keta in the Volta region of Ghana. Our quality improvement aim was that 70% of antibiotics prescribed for pneumonia in outpatients are aware antibiotic policy by June 2020. Next slide, thanks. In the interest of times, I thought I would just, focus on outcomes of the project, but I'm more than happy to discuss the project in more detail if you want to contact me. The slide's a bit busy, but it does illustrate the main points that I want to highlight. This graph shows compliance with antibiotic policy. We collected a sample of 20 patients per week prescribed antibiotics for pneumonia via outpatient prescriptions. The orange line is the median, and initially this was low 18%. Our interventions were a combination of quality improvement PDSA cycles and additional behaviour change interventions. We tested using the app on phones to access antibiotic policy. With the Drugs and Therapeutics Committee, we created a locally adapted policy, and we also tested displaying the antibiotic policy on the wall. Our behaviour change interventions were discussing barriers to change with prescribers and using the data that we had collected to give prescriber feedback on prescribing. The most effective intervention that we saw was actually agreeing a locally adapted policy, which increased compliance to around 70%. However, we did have a sustained overall compliance rate of 59%, and this is even through the COVID pandemic and a full prescriber changeover between March and June. Next slide. Next point, please. Thank you. Sorry, if you just go back, that's great. So we did complete overall increased compliance with policy by 41%, which, as I said, is still sustained. We reduced the use of comoxiclav by 19%, which is an antibiotic that isn't actually per policy for mild to moderate pneumonia in outpatients. Potentially as an unintended consequence, we actually saw a reduction in amoxicillin prescribing, which is first-line agent. And we did see an initial increase in cefuroxime, which is the second-line option. However, that wasn't sustained. Next point, please. Thanks. We overall found the highest impact intervention, as I said, was locally agreeing and adapted policy. We saw a decrease in amoxicillin as a high percentage of second-line antibiotic choice, but we're really not actually able to say at this point whether or not that was appropriate, and it could very well be, remembering these patients actually are presenting to a hospital setting, and also that amoxicillin is actually widely available in community. So this will be our next step, to have a look at this. I think it was really important for me to do this as a quality improvement project. And the most important part of that was actually collecting data over time. This has proven to be an extremely effective tool for starting conversations with prescribers, and it's led to much deeper understanding of the barriers to antimicrobial stewardship in CETA and the day-to-day issues facing my colleagues in Ghana. But much more than that, antibiotic conversations have continued all year, resulting in a culture change for prescribers. They now openly discuss antimicrobial treatment for patients in ways that were never possible before. And for me, what struck me being involved in this project and with regular meetings in the team in Ghana is actually the similarities and the challenges that they face in antimicrobial stewardship. As an antimicrobial pharmacist for over 10 years, it struck me that the issues they face are so similar to the ones that we're trying to overcome in the UK, just with a Ghanaian twist. Issues like patient perceptions and prescriber preferences, which are universal issues, have been identified when we're trying to promote the antimicrobial stewardship. Quality improvement project has given myself and my team valuable insights into prescribing challenges and given a really solid foundation to continue improving antimicrobial stewardship. And finally, the last slide, I was asked to sum up about my fellowship experience. What can I say? It's been an absolute roller coaster. I feel that my contribution and impact to the project was vastly increased due to the fellowship. It had such a positive impact in me. I can genuinely say that it's completely changed how I see the world. It wasn't without challenges, but these were definitely balanced by the overall pride I have now in what we've managed to achieve in the time we had. And the biggest thing for me is the people that I've met, both the chance to work with my amazing colleagues in Ghana, but also the opportunity to work with a fantastic group of my new phone a friend options, if you will. I'm blown away by the impact that my fellows have had, and I hope to continue to work with them in the future. And now I'm going to pass on to my other colleague who worked with me in Ghana, and that's Allison. And it's over to you, Allison.
Hi, thanks. I'm Allison Coburn, lead antimicrobial pharmacist for NHS Lothian. And as Fran said, both of us worked with the same project group. So it was with the Scottish Antimicrobial Prescribing Group, and we were lucky enough to both undertake projects based in Ghana. So my project was specifically to implement an antimicrobial stewardship program in Ghana Police Hospital, focusing primarily on the training aspect. So we started off with our forming our project team, and you can see in the photograph there, it's a multidisciplinary team. And we had a scoping point prevalence that we undertook back in May of 2019. And then from that, used the information from the point prevalence to develop the training program, which was done in conjunction with the local teams, who particularly wanted it to be as relevant as possible, so including case studies of particular patients, etc. And we also compared the Ghana prescribing guidelines with the NHS Scotland guidelines at that time. And then once we prepared the material, we then delivered it in October last year over a 2-day training program. And this comprised a mixture of lectures and also workshops. And we had to actually change the content as we went along. So this kind of illustrated the nature of the training program, in that in Ghana, you had to be able to respond rapidly. So we would perhaps change a presentation into a workshop, make it more interactive, etc., as we went along. And then following that, we developed the action plan, the Antimicrobial Stewardship Action Plan. The training evaluation was performed there was actually 3 parts to it. So we had a knowledge questionnaire, a behaviours and attitudes survey, and an evaluation of the actual training course. The intention was that the training would be delivered with the healthcare staff, and then using a train-the-trainer approach, they would then follow up with training more staff. So this is just a snapshot of some of the results we got from the knowledge questionnaire. So we questioned, there was 35 staff who participated in the training, and then they subsequently cascaded it to over 30 staff. In red, you can see some of the main improvements in terms of the knowledge gained by undertaking the programme, and these were really quite significant. And we then delivered a further questionnaire via our partners in Ghana that showed that the improvements had been sustained for at least 3 months. There was also a positive change in attitudes and behaviours of the staff, so they felt much more empowered towards questioning senior members of staff about antimicrobial stewardship. So there was a definite increase in confidence, and along with the improved knowledge that they gained on antimicrobial stewardship was seen to be very positive. So just in conclusion, the programme was successfully implemented. The training was very effective in achieving improvements in knowledge and staff attitudes and behaviours. And I think some of the key factors that contributed to the successful implementation were the multidisciplinary AMS team working closely with the Ghana Police Hospital staff. And also we managed to harness the enthusiasm of the staff, which was sometimes quite overwhelming, and so that was really positive. So in terms of just the final slide, please, in terms of the Global Health Fellowship benefits, I would say, to me, just to echo everything that Fran said, it's been quite an amazing experience undertaking the fellowship. And I think not only increase in development of leadership skills, but also a much greater understanding of the need for and the difference that an antimicrobial stewardship programme can make to a low middle income country such as Ghana. Also benefits to the NHS, the team of global fellows, more effective education of staff and promotion of key antimicrobial stewardship issues back at base. And also joint projects have been between the countries to both their mutual benefits. Just some challenges, again, as we've seen today, Zoom calls have their moments. So particularly when you're looking at transatlantic across different time zones as well. The other challenge we had was really preparation and implementation of the training programme within very tight timescales, which was a real steep learning curve for myself. Thank you. Now, straight on to the next talk, Scott.
Thanks very much, Alison.
Going over to the went to Tanzania now. Thank you, Scott.
Okay. Thanks very much. My name's Scott Barris. I'm a lead pharmacist here at Northumbria Trust in the northeast of England, and my element that I was focusing on as part of this project was to look at to develop an AMS training workshop package for KCMC, and we began this with we picked out some of the leaders from KCMC that we really needed to help us to undertake this work. So there we can see a little picture there was where we some of the visitors we went to visit the Duchess of Northumbria, who's a big supporter of our charity work in Northumbria. So this included Chief Pharmacist, the infectious disease consultant, and our Chief medical lead at KCMC. And in those 4 weeks, part of that, we co-developed an AMS training package. And what we wanted to do was make sure that that was going to be relevant to lots of different areas, so we could capture as many people as possible to get the message out there around resistance and appropriate use of antimicrobials. So we produced some designed some formal lectures, some classroom activities. We also went on to make some case-based discussions, posters and role play. And we then went on to look at whether we could have some specific training within the public sector as well. So we managed to capture a lot of the healthcare staff, but we also wanted to capture the public element at the same time, and that went into some of the schools, so the primary schools, and also the healthcare schools as well. But we also actually had an opportunity to speak to some of the boda taxi drivers. We were doing some training around, because there's a lot of accidents that happen in Tanzania on the roads, and we wanted to actually get the message across around AMS at the same time, so that they could again get into discussions with some of their passengers, and it really worked fantastically well. Just want to go on the next slide. Okay, so the results were that I know there's lots of information here. Overall, over the 2 visits that we then returned to go to KCMC, so one in June and another one in November, we managed to get the message around AMS to 1,056 individuals over that time, which was fantastic. So that was only a 4-week space of time when we were doing that. So we achieved such a huge amount. I was really, really proud of what we did. And to be honest, following our 4-week preparation, when we first joined the Tanzania team, that pharmacy team really just completely took the lead with it and just rolled with it. And since we've been doing this work, they've continued to lead that on since we've done the work. So it's been really, really fantastic. Just go on to the next slide. Overall, I think for me, I think this has really been a big lesson around what influence you can have as a leader. So, if you just think about what team you work in, you may just think, well, my influence is, the people in the room here, or it could be, my department. But actually, you are really selling yourself short. You can have a much bigger influence regionally, nationally and globally, and you really should have the confidence that you can do that. I think that this really has helped put pharmacy profession on the map and just demonstrate the intervention that we can make in some really difficult subjects like AMR. As a consequence of the work that we did, we've now got clinical pharmacy developed in Tanzania in KCMC, which we hadn't planned for initially, but this is something that's probably going to be the biggest influence and the biggest interventional part of this project that will see a big change, and again, pharmacy leading on that. And finally, I just wanted to say that this has really started to show the pharmacy profession and the interest that I actually had here in Northumbria around overseas work was massive. And in the end, I managed to get sort of 5 pharmacists from the UK and 3 pharmacists from KCMC to get involved in overseas work. And really the demand is much, much bigger, and we need to see if we can find more channels where we can get this ability for people to experience this in a much greater way. Thank you. Just hand over to Joe.
Thanks, Scott. As Scott said, my name's Joe. I am also I'm one of the senior pharmacists at Northumbria Hospital. But as you can see from my picture, I'm coming to you from the Ngoro crater today. So I'm in a slightly sunnier part of the world. So my sort of part of this project that I was taking the lead on was all around the data collection. There was quite a bit of trepidation from the team before we went out as to, it was an unknown. We'd never done anything like it before. We didn't really know what we could achieve. And as you heard from Scott, we achieved loads in the end. But we sort of said before we got there, if we do nothing else, we will have data on antimicrobial prescribing and resistant patterns in Tanzania and in KCMC Hospital, which would be a first. So that was really high on our priority list. So it really was about data. So when we first got there, we set out with a training program with the team at KCMC around the GPPS, how to do it, what we were looking for, that sort of thing. And as a result of that, we ended up with data for the first time, robust data, which we could compare against other hospitals in the region, similar types of hospitals, that sort of thing, which really was a first. We screened about 985 patients, about 400 of those were eligible to be included. So we had a pretty robust data set which we could work with. and that was what we used to target our interventions for. If you could have the next slide, please. So we wanted to ensure we both celebrated the good as well as sort of spotting trends and using the data that way. So for example, in KCMC, they are fantastic at their documentation. They're really good at documenting in the notes the reasons for antimicrobial usage, and that's something we've brought back to our trust here because as you can see, they're better than the data from Europe at KCMC. So that was a really positive thing and something that we thought was important to celebrate. And we also used the data to look for trends. So we identified that there was a relatively high usage of quite broad spectrum antibiotics, particularly in things like UTI treatment and chest infections, in antibiotics which we know there can be resistance to. So we identified that early on in the project and thought we would target our interventions towards those sort of things. Next slide, please. So those interventions were varied and we did loads of different things. So you can see along the photos, the top here, we had training programs, which Scott has spoken about. We had IPC programs, so introducing hand sanitizers to the wards, doing audits on the use of those hand sanitizers, educating staff around why hand hygiene and things like that are good, bare below the elbow programs. We spoke to the School of Pharmacy, the local School of Pharmacy, to introduce that grassroots program, which we've been talking about. So, you know, get that training embedded into early year pharmacy training to make sure that it's there from the start. We did clinical pharmacy training with the team at KCMC about how they can make interventions on the wards. And we also introduced guidelines through the microguide app, which the CwPAMS program generated. And all of those things essentially produced a really positive shift in not just the deliverables we were looking at, but across the board. So I've just shown one of the comparators below there. So that's the PPS we did at the start of the program and towards the end in November of the program. Ampicillin usage, which was sitting at around 20%, it was one of the highest used antibiotics. This is for community-acquired pneumonias, dropped off the scale. It went so low that it went from 20% way off the scale. Because we identified it and they reduced their usage of that. And the same for ceftriaxone, it went from about 70% to 45% usage, with other antimicrobials coming through and their uptake increased as a result of all the things we did. And I think it's important to highlight that having the data in itself is a fantastic achievement, but it's what you do with that data. So we were, some of the earlier speakers were talking about being able to influence policy at a higher level. And we now have pharmacists in Tanzania sitting on antimicrobial steering groups at a national level, talking about the data that we collected as part of this project. So really positive impacts there. Last slide, please. So for me, just to reflect what everyone else has said, the fellowship has been so impactful for me personally and for my career. It's hard to imagine that it's just a year since we started because so much has changed. I've taken on projects back at within Northumbria around antimicrobial prescribing, and I've taken the lead on them. I've progressed my own career. I've talked about this to anyone who will listen, and it's really had such a positive impact on me and my career. So a big thank you to CPA for the opportunity. So I'm handing over to Esmita, I believe now. So over to you.
Thank you so much, Joe. Hi, everybody. It's such a pleasure to join and hear all the amazing work being done. So my background is slightly different in that I wasn't part of any specific project, but my fellowship was with the CPA and the Office of the Chief Pharmaceutical Officer. And it was through the support of Diane and Sarah, but also Professor Allison Holmes at Imperial, that I was able to join this program and to deliver some things at last minute and some things we will be doing long term. So next slide, please, Diane. So really, it was through the connection with Sarah and our long-standing collaboration and work that I was able to join the projects at very last minute. I think I had 5 days notice to go to Ghana and Uganda, and I was almost not allowed into Ghana because of my vaccination booklet not being up to date. But if it wasn't for the networking, the global health experience and flexibility and the work with Sarah Kavanagh, I don't think I would have been able to join so quickly. And I ended up with the team from FET and CPA going on the inception and monitoring visits in Uganda and Ghana. And really it proved to be important to be present, to have representatives out there to look at the progress of the projects, but also to work very closely with country representatives. And we had great support from Winnie and Peter in Uganda for that. And in addition to the fellowship, I also had specific targets and objectives to meet. In addition to the inspection and monitoring visits, I had to work on preparing a report on how we can better support the clinical pharmacy profession in these countries. And that's something we're now working. And I have to say thank you to all of you, some of you who've already contributed to the report. Massive thanks. And we will keep sending the draft round to make sure that we produce something that is has everybody's input and is also builds on the learning that we have had, all of us collectively, as part of these fellowships. So that will come your way at some point. Other two things I want to highlight is what this fellowship has enabled is the links that we have built with Uganda and the experience we have in South Africa and India on stewardship. I've been able to link colleagues. So we developed a massive open online course on antimicrobial stewardship with input from Ugandan colleagues and support from the CPA. And that's been accessed by over 2,000 learners in 50 countries and is going strong. In fact, during COVID-19, we had a lot more learners participate and really good feedback on what stewardship looks like and the pharmacy involvement in different countries. Last slide. Diane, thank you. And the other thing I want to mention is we were also able to link the Uganda colleagues with colleagues in South Africa, and they've written a grant together on implementing stewardship and surgical pathways, and hopefully that will lead to further collaborations. And to summarize really what the fellowship has meant for me, it's been wonderful to see how all the amazing work that's been done here, but also to be able to build on the collaborations that we were able to develop through this fellowship, and to also evaluate my own learning and leadership skills, and try to connect people across the CPA with colleagues, pharmacy colleagues in India and South Africa and Uganda and wider. So that's something I want to build on now with through this professorship that I have with India, UK, but also to bring that into the CPA. Thanks to everyone, especially to Sarah Kavanagh and Diane and CPA for all the support.
My name is Fiona Ruiz and I work at the Brighton Sussex University Hospital Trust and have done our fellowship via the University Teaching Hospital in Zambia. Next slide, please. We're part of an established health partnership already, the Brighton-Lusaka link, which was mainly driven by medics before the CPhO project came along. But now pharmacists really are at the forefront of driving through the antimicrobial stewardship and the infection prevention control elements, which is great. The first task that we set out to do, The first task that we set out to do in the programme was to train a workshop, which was done in June 2019. And here we shared current landscapes and strategies for AMS. And the facilitators for the day were from Brighton, from Lusaka, and also our sister hospital, Ndola, in Zambia as well. 23 trainers were trained and feedback from the workshop was very positive. And throughout the workshop and thinking about the interventions, we really wanted to ensure that they were part of the AMR WHO competency framework, which was on the next slide. Thank you, Dan, next slide. With regards to my project and what I was going to lead on, the brief for my project plan was very broad. It just said to optimise the use of antimicrobials and improve IPC practice, which meant really I could get involved with lots of different things, which was really helpful because it obviously coexists, but also because it was really useful for my development. From the stakeholder event, it was deemed essential that an AMS pharmacist was employed, which was done, and they've been really pivotal in driving a lot of the work through at UTH, which has been great. And one of my first jobs was collaborating with this pharmacist for the development of UTH-specific antimicrobial guidelines, because the ones that were published from the national lead in Zambia were out of date and often actually were ineffective because of the high resistance patterns, especially seen at UTH. This was also done in collaboration with the University of Maryland, because they do a lot of the resistance monitoring there at UTH. They are ready for sign-off, but unfortunately due to the current COVID issue, they are just being deferred while they deal with other things. With regards to Global Point Prevalence Survey, we thought it was really important that we get the data like other fellows have mentioned. But when we mentioned this to our Zambian colleagues, they were really nervous actually of getting it done because they've never had to do such a large-scale data collection themselves. Therefore, to try and help with this and to ensure sustainability of GPPS going forward, I worked with the lead to organise a pilot, which we did together during my visit to UTH. And this was very successful and then enabled further GPS data collection a few months later, which was great. As part of the AMS project that we have in the Brighton-Lusaka link, there was also a specific antimicrobial chart that was developed. I wasn't involved in the development of the chart, but I actually led on the training material for the chart, and then the launch of the chart was led by our Zambian colleagues. Excuse me. Also, what was thought would be really useful for AMS was actually a training program that could be done through all different cadres of healthcare professionals. And I led on the initial development of this training program. And since actually it's developed into a much bigger thing, and now it's being taken over by a Zambian-based expert panel, which is brilliant, who have developed it into a modular-based system, which has been signed off by the University of Zambia and is now looking for accreditation through the national associations. With regards to IPC, when we were there, it became very apparent that bare below the elbows wasn't actually embedded within practice within UTH or Zambia as a whole. And when they learned of the evidence, they thought it was very necessary that it becomes embedded. And so I developed the approval pack for bare below the elbows to be approved by the national associations, and also developed the training for this, which was then incorporated into the IPC training. And this included general training, but also posters. As part of this project, we also used funds to develop a alcohol hand rub production facility within UTH, which before COVID was making about 40 litres of alcohol hand rub as per the WHO formula. And when COVID hit, this increased up to about 120 litres per day, which was actually extraordinary and also very helpful. From this information, then we were able then to secure funding from another FET initiative, the Health Worker Action Fund, to secure funds to increase this production into 3 additional hospitals in Zambia, which are the 3 other teaching hospitals. And so now they're able to produce hand rub, which has obviously been very beneficial during COVID. So not directly part of this project, but definitely a link. And then another link with the project is on the back of that, we actually helped the CPA make educational videos on the production and use of alcohol hand rub, and that's been available and being used in the last couple of months. We've had a few publications in the PJ, and in it's been had an abstract in the FIT conference that's coming up. And Diane, thank you, has just shown some pictures of the work we've done, which shows the antimicrobial chart, the IPC poster that we developed, and also some of the training and the hand rub production. Next slide, please. What's meant to me really has been echoed by all my colleagues. It's really been about the networking and the feeling of self-worth and helping out other people. Also, I completed an MSc in global health, and so it was amazing to be able to put this actual course into practice. What I think has been really good for the NHS specifically at this time is actually our Zambian colleagues were able to teach us in BSUH how to produce hand rub, and that's been done by the University of Sussex. So that's been an excellent thing that's happened. The only challenge that we had really is about monitoring and evaluation, but we've now commissioned a training course in order to improve this. I just want to say thank you very much to all of my colleagues in Brighton, in Zambia, and to our fellowship, and thank you very much for listening. I'll now hand over to Reem for her project. Thank you.
Thank you, Fiona. Hi, my name's Reem Santos, and I'm a principal pharmacist in antimicrobial stewardship and infectious diseases at Cambridge University Hospitals. Next slide, please. The Kampala-Cambridge partnership was built on an established 10-year partnership between the UK's Cambridge University Hospitals, NHS Foundation Trust, and the Department of Obstetrics and Gynecology at Makerere University in Uganda. This partnership brought together healthcare staff from CUH and 2 Ugandan hospitals, CwPAMS National Referral Hospital, a government-funded institution, and Malago Specialised Women's and Neonatal Hospital, also referred to locally as the Women's. which, although nationally owned, was privately funded. The partnership adopted a multidisciplinary approach and recruited healthcare workers from diverse disciplines, including medicine, nursing, and pharmacy. 2 behavioral scientists were a unique addition to our team, playing a key role in strengthening the project through translation of behavioral theory into practice. Next slide, please. The overall aim of the project is to reduce infant and maternal mortality in the 2 hospitals. During a scoping visit in June last year, we observed suboptimal hand hygiene practices in the clinical areas we visited due to deficits in infrastructure. We also observed lower than expected patient numbers at the Women's Hospital, mainly because there was a charge for its services. In CwPAMS, they were faced with the opposite issue, a surge in numbers by comparison. To better understand the barriers of hand hygiene in resource-constrained settings, we conducted a literature review. Then we used a behavioral science approach using the COM-B model, the behavior change wheel, and behavioral change techniques to guide the development, design, and evaluation of interventions to improve the use of hand hygiene through increased uptake of alcohol hand rub, as that seemed like a viable and practical solution to the infrastructure issues. Finally, we developed a set of 12 interventions to address our target behavior. Behavioral functions such as education and training noticeably addressed one of the common personal barriers to hand hygiene: poor knowledge and training. A customized training program was subsequently developed in collaboration with the Ugandan partners. The course was designed with input from our 2 behavioral scientists in order to maximize engagement with the content informed by the behavior change techniques identified from the scoping visit. In total, 48 healthcare workers across both sites from a range of disciplines were invited to attend a 2-day training workshop. A further half-day training session was provided for members pre-selected to form the Medicines and Therapeutics Committee. The MTC would have oversight of antimicrobial stewardship and infection prevention and control. During the training, we presented evidence to healthcare workers about the risks of infection and the role of hand gel to minimize the risk. We demonstrated how to wash hands and use alcohol gel correctly, giving trainees an opportunity to practice this skill with feedback. We also set out to improve knowledge through well-designed posters to remind the healthcare workers about the negative consequences of poor hand hygiene. This also acted as a persuasive tool through the use of emotive imagery to encourage reflective motivation. Use of visual cues such as agar plates to culture bacteria from fingerprints served to highlight the importance of hand hygiene during the training. Restructuring of the physical environment and increasing the availability and visibility of alcohol gel dispensers in clinical areas was also a key intervention. Following the training, a multidisciplinary infection prevention and control team was created at the Women's, with the aim of actively promoting AMS, and a dormant IPC committee at CwPAMS has been revived. The role of the pharmacist has become an integral part of the MDT and MTC as a result of the partnership. In the government hospital, administrators supported the in-house alcohol gel production to achieve a more affordable and sustainable source of alcohol gel for the hospital. The first batch was released in February this year to coincide with the launch of the new dispensers throughout the hospital. Other pharmacists at CwPAMS have been subsequently trained and ensure a consistent supply is available to meet the needs of the hospital. Alcohol hand gel supplies for both hospitals can be seen in the graph before you. We suspect that the huge increase in the privately funded hospital is in preparation for COVID. Further changes to the physical environment at CwPAMS included the purchase of sinks so that hand washing facilities would be available. Other positive outcomes for pharmacy include the regular rounds created by one of the pharmacists at the Women's Hospital, which promotes the clinical value of hospital pharmacists. In addition to the qualitative data that we collected, measures of knowledge of antimicrobial stewardship and related behaviors were obtained pre and post-training. Results showing the training increased knowledge about the importance of alcohol hand rub by 17%. Looking to the future, we feel that the key to attaining and sustaining high rates of hand hygiene practice is to embed infection control and AMS into organizational culture. This can be achieved through the MTC. Some examples are listed on the right-hand side of the previous slide. In the interest of time, I'm going to hand over to my colleague, Preet. Thank you.
Thank you, Reem. My name's Preet. I'm the lead antimicrobial pharmacist at University College Hospital. Our project was capacity sharing for antimicrobial stewardship through the MTC committee, quite a long name, so CwPAMS for short. There's quite a lot of partners that are involved in this project, so you can see lots of symbols at the top. We had about 6 or 7 different partners involved. I thought I'd put the Ginger Bridge, which was a nice sort of fitted theme, building the bridges between UK and Uganda, which seemed to quite fit the theme for Ginger. So that's the bridge over there. Next slide, please. Ginger Regional Referral Hospital is one of 16 regional referral hospitals in Uganda. It's a tertiary referral hospital, and it's got a bed capacity of 474. It's based across 2 different sites. It also serves as an internship hospital, so graduates of medicine, pharmacy, nursing, and other allied health professions will undertake their residency here. And it's got a whole load of different specialties as well, and quite a varied outpatient department. Next slide, please. So one of the objectives of the Ugandan National Action Plan is to establish or strengthen antimicrobial stewardship programs, and in hospitals these seem to be coordinated through the MTCs. So our project goal was to strengthen the AMS roles and responsibilities of the MTC committee and develop its capacity to optimize antimicrobial use. So we set out to co-develop with the Ginger health workers an MTC which would be focused very much on AMS and undertake a baseline situational analysis to be able to feed into this. So we wanted to identify prescribing practice by conducting a global point prevalence survey, assess the capacity of the health facility and also the awareness of health workers. We undertook educational workshops, and on-the-job training was provided to increase the knowledge and the capacity of health workers. And this is all complemented by supporting the MTC develop their processes and procedures. And if you press the next slide, please. This is the MTC committee in the background. This is by the Ginger Hedge at the hospital. So it's a multidisciplinary committee composed of 15 members. It's got doctors, nurses on there, and the pharmacist, who is the secretariat, is hiding in the background over there. But they also have a biostatistician, and they also have a community worker, which I thought was a really nice thing and something that we've learned really from their committee. Next slide, please, Dan. Thank you. In terms of results, GPPS data was collected over about 5 days, and this was done by the Ginger staff. So they were trained and they did all of that collection. And what we found was that the prevalence of patients receiving at least one antimicrobial agent was at 56%. Comparing this to some of the other Ugandan hospitals that have presented their GPPS data, Ginger seemed to have quite a high prevalence of antibiotics, both in adults and pediatrics. We're not quite sure why that is, probably related to the fact that they're a regional referral hospital, but we're trying to work with the teams to try and understand these data and the implications of use. And as you've seen from other presenters, here's a slide of the types of antibiotics that get used at Ginger, which is very similar to most of what else is used in Uganda. In terms of health worker awareness, if you could press the next button, please, Diane. Thank you. The awareness score of the health workers is actually quite good. They have a very good mean awareness score of about 76%. They stated that they have good enough water and power supply and also cleaning materials at the hospital, but they often ran out of stock. Their storage facilities are not really suitable, and they don't often have enough staff to clean the wards. The range of diagnostic services are not sufficient, so that's something that needs to be improved in trying to improve AMS. We did lots of consultation and engagement with key stakeholders, and also particularly the MTC committee, which you can see in the picture over there. And this helped really inform the plans for implementation of antimicrobial stewardship interventions, which are very specific to their local setting and to their local needs. So a number of educational workshops were held, which consisted of lectures, of practical sessions, and of group work. And very much, really, we were so impressed that the health workers came up with their own solutions of how to improve antimicrobial stewardship. There was also a pre and post test which showed that their health worker knowledge increased from some baseline of 49% to 67%. Next slide, please, Dan. Thank you. So in conclusion, in this short project, what have we achieved? Well, Ginger have a formalized MTC committee, which is what our key goal was. They have a very detailed work plan of implementing antimicrobial stewardship. They've already produced their own local guidelines, particularly for the management of bacterial sepsis and UTI, which are available on the wards. And that was something that we heard very much from them that they wanted to do. They've also done another local point prevalence audit, and they've identified a number of audits, particularly to be led by the nursing teams, looking at around sort of IV and oral use of antibiotics. We've delivered training, and as shown previously, the health worker has increased their knowledge and capacity. And as something that we brought back to the UK, what we found was, although we talked very much about developing a committee and how AMS works, we wanted to show a practical way of how this is done. So we have developed a very short video showcasing antimicrobial stewardship in a UK hospital. And this is something that we're going to use as a training tool for all our new staff that start here, so that they have a better idea of how AMS is run at UCLH. Next slide, please, Diane. And this is what the fellowship has given to me. I think everybody has said all of the above things already. I think the great benefits of developing collaborations, which would never have happened really without the fellowship, and the networks, particularly with the rest of the fellows, and the support received from them, because a number of times throughout the fellowship I often felt I really can't do any of this, and having the support from the rest of the fellows has been superb. Clearly, sort of really appreciation for the NHS, and that's coming to light very much so, particularly during COVID. And on a personal note, I was given the opportunity to present at the Infection Prevention Network Conference in Kenya, so meeting other like-minded colleagues across the rest of Africa as well. So I'm really grateful to CPA and Diane and others for helping support that. And I think I'm going to hand over to Amrit now.
Hi everyone, it's Amrit. Hope everyone is well. I am so sad not to be at the virtual study day today, but I have been detained by the powers that be, and I'm doing this pre-recorded Acceptance Speech Academy Award style presentation for you. So here we go. My project was based at Fort Portal Regional Referral Hospital in Uganda. I was looking at antimicrobial use on the maternity ward and looking at the impact of a pharmacist and their intervention on the daily ward round on the ward. The hospital is near the border of the DRC, so it boasts ID lab, so we were able to look at the bacterial genome and the cultures and sensitivities of the samples, so we could present this data at the local IPC meeting. And this whole project really had a positive impact and highlighted multidisciplinary training and frontline integration to provide sustainable, keyword, outcomes. So here's some pretty pictures looking at the genome and the sensitivities. Very complicated. I'll move on to the next one. There's me looking great, presenting at the IPC meeting. Third one's a water canister, which I'll go into in a moment. And there's lovely Joe and Alan using the VR system for training, a different approach, and then us on a mountain. So what did I learn through this opportunity, this fantastic opportunity? Numbers are subjective. We look at numbers, we do a pre and post test of an education presentation. I think we've achieved something because people pass the test, and the next day people don't wash their hands, and it happens here. We need to change the way we teach people, and integration is key. We need people to be on the front line every day. So, and just the other day, when I was doing this SBR introduction to a hospital, I completely gutted the old presentation, got rid of it, and changed it to a more integrated interactive learning session, and the evidence was instant, because as soon as they got to the ward, it was the chemotherapy prescribing was much better. Attitudes matter. Positive attitudes are more likely to retain knowledge than negative, and apathy and disenchantment is a big problem right now, but we need to overcome it, and the only way to overcome it is being a good positive role model. Why? Because small change is big change. If you can change the attitude of one person, you can get them to teach a positive thing to the next person, so it doesn't just rely on you, it's everybody training everyone else. Then next we have to kiss everybody. I'll go back to the water canister to explain my point. Keep it simple, stupid. This water canister had a clay pot, which is accessible and simple and elegant to filter the water. It didn't have a fancy filtration system. And this is what resonated with me. I need simple, elegant ideas to provide the biggest and life-affirming change. And then finally, we need to be ourselves. We need to not present the best version of ourselves constantly. We need to show what the energy and effort it took to present the final project, because that's what we need to improve on, and that's what people learn from. People learn from each other's mistakes, so they won't do it to provide a better product. And that's why positive and personal reinforcement will be important to develop people and training to provide the best patient care. Thank you all so much for your help. Thank you for listening. I'll be excited to see your presentations later, and I hope to see you in a socially distanced way in the future. Bye for now.